Thank you so much for having the colorectal surgery program here today. I am honored to present with my colleagues and demonstrate the amazing team that we have here to help care for our colon and rectal surgery patients. It is truly a multidisciplinary team approach, so it is important that we see that from all aspects and see how that affects the quality of care for our patients. So I am going to be speaking with Barbara Annunziata, Laura Benedetto-Rugen, and Angela Giulianti today, and I will introduce them as their part comes on their slides. So this is just a quick overview of what we're going to be looking at. Going to overview the colorectal surgery program. I'm also going to give a detailed look at the multidisciplinary team approach. We're going to go through the patient journey from an enhanced recovery perspective, which Barbara will give details on. Then we're going to go through a patient journey from an inflammatory bowel disease perspective with Angela, which we'll review. And then Laura will represent the ostomy team to also provide a little insight onto how they provide a role within the quality of our patient care. And then we're going to go into the details of the community outreach that we are involved in within the community. So as of January, we are now a digestive health center. So what is a digestive health center? It was created to improve the care and coordination of care for patients with GI and medical disorders. So programs within that are going to be anything within the GI tract. Specifically for us, we'll be addressing the colon and rectal surgery program today. That includes the fellowship, our rectal cancer program, as we are a designated center of excellence. That includes our GI medicine patients that will be cohorted on our designated surgical floor, advanced GI, inflammatory bowel disease, and bariatrics. But for the purposes today, we're going to directly address our colon and rectal surgery patient population. This is our team. You can see our respective leadership, which is Dr. Greenwald. He's the Surgeon-in-Chief, Chief of the Colorectal Clinical Service, and our Rectal Cancer Program Director. Dr. John Procacino, who's the Chief of Colorectal Surgery, and our Fellowship Director, and recently joining Dr. Feza Remzi, who is the VP of Northwell Inflammatory Bowel Disease. And you can see our colleagues here as well listed, the surgeons. Most of these are familiar faces, but a new face you'll see is Dr. Armand Erkin, who joined the Inflammatory Bowel Disease Center. And of course, importantly, our partnerships in care for our colorectal surgery partners. This is a very multidisciplinary team approach. We have the nurse management team here, and we also have our clinical care team listed below, which is including the registered dietitian, physical therapist, our ostomy team, as well as our partners in patient-centered care, and also our nurse case management team. So just an overview, like I'd mentioned, North University Hospital, we perform over 700 procedures from a colon and rectal perspective annually. We are nationally accredited Rectal Cancer Center of Excellence. We ranked number 12 nationally and number 4 in New York. We have wonderful accolades, as you can see, little indications, and just in terms of our specialization, we do have a designated floor as well as designated nurses and an ostomy care team to manage our patients. Also just wanted to, this is very Monty focused, but there are many different nurses that interact with our patients from a pre-surgical testing, same-day admissions, operating room, PACU, 2 Monty and the ostomy nurse team, 9 Monty, IR, endo, case management, outpatient offices, our rectal cancer coordinator, and our robotics program coordinator who interact with our patients from a nursing perspective. And in terms of the multidisciplinary team approach, again, there was a lot of education that went into this from a nursing perspective. We do annual ERP educations, I-Learns, ostomy team patient education, as well as staff education, ERP QR codes and posters, bi-monthly divisional meeting and partnership, and also since we've become an inflammatory bowel disease center, pain management, PCA education, ostomy team education, and PICC line education. And then a brief overview again, the 2 types of patients you'll see within our program. You'll see ERP in the green column, types of surgeries, laparoscopic, robotic, LARs, pretty minimally invasive. We see about 40 of those cases monthly. They stay 1 to 3 days for the reversals and about 3 to 4, even shorter, sometimes 2 for an LAR or colectomy. Those are patients that are usually local to the area. Some of their comorbidities will include diverticulitis, inflammatory bowel disease, or malignancies. And from our inflammatory bowel disease perspective, the patients will usually be undergoing a 3-stage pouch procedure, colectomy, pan-proctal colectomy, and an ostomy reversal. We see about 40 of those cases in addition to our ERP population. Those patients have a longer length of stay, and demographics-wise, they're usually younger due to the nature of the inflammatory bowel disease. They do travel nationally, and we will start to see international in April. They have different needs from a care perspective, travel, pain control, TPN, and marking, and they usually have undergone previous operations. So it's just a brief overview of our pathway, what it looks like, how ERP falls into our patient population, and the steps that they pass through, and everybody who's involved in managing their care. And I will now turn it over to Barbara Annunziata to take us through an ERP pathway.
Thank you. So, hello everyone. So I know as well as I have seen a lot of changes in the hospital, especially at bedside care. And I have to say that one of the best ones is enhanced recovery protocol. I think we were a little skeptical at first, but it's amazing. What it does is it enhances early ambulation, early PO intake, pain management with minimal use of narcotics, which is amazing, decreased length of stay, decrease in surgical site infections, and a decrease in readmissions. So what are the pathways that we use to ensure that the enhanced recovery protocol or ERP, that we're in compliance with it? So as Megan said before, we have annual in-services, iLearns, which we can't get away from, QR codes, we have education binders on the floor, ostomy patient and staff education with our wonderful ostomy team. And we have posters on the floor that actually, if anybody has an opportunity to come to Tumanti, there's a great poster on the ERP protocol at the nurse's station, and it gives you all the information you need to know. It tells you pretty much what you need to do. And we have, of course, the EMR documentation standardization, which makes it easier. So what is a lower anterior resection? We have a little video, a very small clip.
So the volume didn't play. I'll just voice over it because I did write the script, so I should know that. So this is the little area here that I'm showing with my arrow. These are the area here has diverticulitis. It's the infected bowel or the diseased bowel in this case. The resection lines are noted here where the staple goes across the bowel. The anastomosis is reattaching these two blue lines back together, also known as the sigmoid colon. And when that connection is reattached, intraoperatively, we'll take a look and sublate the colon, make sure there's no bubbles, fill the abdomen with sterile water. Once we see that that is safe and that there is no leak within the anastomosis because the tissue is perfectly healed over, we will close the patient from the skin. If in that case there is any issues and there's bubbles, that's where we would have a diverting ostomy.
Okay, and you can see the scope sites for the lower anterior resection in A, that when the patient comes from the recovery room, you will find that they have 5 scope sites. Okay, so what is the pathway to recovery for an ERP patient? So we have an example of a 45-year-old female. Her name is Colonna, with multiple episodes of diverticulitis, but no surgical history. But she is scheduled for an elective LAR on Tuesday, 3/26, with Dr. Greenwald. However, on Monday, she calls her primary care physician and she says, I just don't feel well. I feel a little lightheaded and dizzy. He tells her, come into the office, and he diagnoses her with hypotension, but he tells her, get to the emergency department, pending your surgery tomorrow. So she goes to the emergency department, she's stabilized, she's admitted, and she's transferred to Tumanti. And she is cleared for surgery on Tuesday, and we'll be prepping her on Tumanti. So When she comes to Tumonte from the ED, what do we need to make sure that she has done? We need the labs because she's pre-op, coags, type and screen, CBC, BMP. We need to do the chlorhexidine wash prior to the surgery with a new gown in place, urine for pregnancy, an EKG, and medical and cardiac clearance is done. Then preoperatively, prior to the surgery, 24 hours prior, we're going to be bowel prepping her. Antibiotics, neomycin and Flagyl will be started 24 hours prior to the surgery. It'll be 24 hours, 16 hours, and 8 hours. And then Miralax every 2 hours up to a total of 8. Her diet will be, this is really the big difference that still boggles my mind, that they're allowed to have clears up until 2 hours prior to the surgery. Once they hit the 2-hour mark before the surgery, they're NPO, and we need to assure that they're drinking their Ensure pre-surgical drink. So now Kelowna had an uncomplicated laparoscopic LAR, and she's brought to the PACU. And once she's met all the PACU criteria, she's then transferred back to Tumonte to room 215 window with myself as her nurse. And of course, in the meantime, I've gotten report from PACU. Okay, so now Kelowna arrives to the unit. It's her post-op day really 0. So what do we have at the bedside? Continuous pulse ox for 24 hours because she did receive spinal doromorph in surgery. And we know that it is a morphine medication and can cause respiratory depression. So it's important that we have them hooked up to the pulse ox. Incentive spirometer, which is all of these things are really any post-operative patient, incentive spirometer, the PAS stockings, and the IV pump. And of course, make sure that the call bell is in reach because we don't want them getting up by themselves. So I'm reviewing the PACU vitals, post-op vital signs every 4 hours. Every hour times 4. Subcutaneous heparin will be given every 8 hours. Our IV fluids, which is pretty standard, LR at 40. An hour, clear liquid diet, and we have to make sure that the patient does get the tray because sometimes we know that, it could happen that they don't get it, or I like to set them up though with a few things at the bedside as soon as they come in. And we'll be doing first out of bed if it was not performed in PACU. Many times it is, in addition to giving them some clear fluids, and which is very good for the patient. Ileostomy and colostomy care, which if it's appropriate, if the patient, is able to receive that information, and that will also be done post-op day 1 and 2 to discharge. So on post-op day 1, Kelowna is doing very well, but we have to make sure that we're doing strict I's and O's. We're starting the patient back on her home medication, whether it be antihypertensives, her Synthroid. Also, she's getting standing doses around the clock of IV Tylenol and Toradol. And then we will advance her to PO Tylenol and PO Motrin, which she will be taking when she goes home, also for pain control. After she has 2 clear liquid trays that she's tolerated, no nausea, no vomiting, no abdominal distension, we'll advance her to a low residue diet. And once she's tolerated 600 cc's of fluid, of oral fluid, tolerating the low residue, we'll DC the IV fluids. We'll discontinue the Foley catheter on day 1. Also, the ostomy team will come and see the patient, ostomy education if needed, registered dietitian, and physical therapy if, which Kelowna is not, greater than 55 years of age. So post-op day 2 to 3, we're looking at discharge information. So she's tolerating her low fiber diet. She has adequate bowel function. She is passing gas, passing flatus, may not necessarily have a bowel movement, but that may happen at home. She'll have, if required, physical therapy recommendations and outpatient physical therapy, adequate oral pain medication, home care setup by our case managers, and patient education and discharge readiness. So she's ready. Kelowna is going home, and she's looking to get out of here. She's got 9 toes out the door. So what are we going to be talking to her about? Her medications, her diet, her activity, her medical doctor follow-up in addition to the surgeon, ostomy care reinforcement, her supplies, collaborating with case management to ensure that any home care needs are initiated, and also wound education, dressing changes, and drains, all part of the education. I really, I don't know if some people realize it, but on the discharge instructions, there is a spot where the nurse can write in some nursing instructions. And this is pretty much what I say for most of my surgical patients, but of course I tweak it personally if there's a drain, and of course if they don't have a stoma, it doesn't say this, but for all surgical patients, it should be temperature, nausea, vomiting, any increased pain that's not improved with pain medication. They need to be checking also the site every day for redness, swelling, bleeding, drainage with foul odor, because we know those could be signs of infection. And then with ostomies, any changes to the stoma color, the size, or any significant increase or decrease in the ostomy output. All right, so we have Angela Giolante, who will be talking about inflammatory bowel disease and her patient's journey. Thank you.
Hello, everybody. My name is Angela. I've been a nurse on Monty for about 3 years now. So I'm going to walk you through how our inflammatory bowel disease patients, what their journey looks like, and what kind of care we provide for them. All right, so what is inflammatory bowel disease? So it gets broken down into two categories. There's ulcerative colitis and Crohn's. They are very similar. They're both autoimmune disorders that are inflammatory. But the biggest difference is that ulcerative colitis strictly focuses on the large bowel, whereas Crohn's disease can affect anywhere throughout the GI system from the mouth to the anus. With Crohn's disease, we usually see more fistula formations, more strictures, and things like that. They both come in stages of mild, moderate, and severe. These patients usually are going to the bathroom like 10 to 15 times a day. So it is very debilitating, and a lot of times it gets misdiagnosed. The best way to diagnose these patients, the gold standard, is through a colonoscopy. While they do that, they'll take a couple of biopsies of the tissues, and that is the best way to diagnose these patients. Some symptoms that you might see are abdominal pain, bloody diarrhea, frequency going to the bathroom, things like that. So some nursing education for our IBD patients is ostomy nurses are on board throughout the entire process. We have a lot of increase of ostomies due to our new surgeon, Dr. Ramsey, who's been amazing. But the ostomy nurses are working hard and they're always at the bedside and able to help us if we have a difficult ostomy, things like that. PICC lines and ports are starting to become more common as well if they need TPN, or a lot of them are getting outpatient medications like Stelara for their Crohn's disease. TPN education if they need those additional nutrients after surgery, if they're not able to tolerate their diets. IBD surgeon education, so we have Dr. Ramsey, who's been amazing, and PCA and PCEA pain medications have been huge. So pain services and ostomy nurses are our go-to people with these patients. They're chronic patients, so they have chronic pain. So it's important for us to be mindful of those things and give them a lot of tender, loving care. All right, so now we are going to have our disease pathway. So now we have a 21-year-old male. His name is Sigmoido. He has a very significant past surgical history with ulcerative colitis. He presents today for an elective stage 2 procedure of the J pouch. So Dr. Ramsey is world known for his J pouch surgery. So it does come in 3 parts. There's the end ileostomy creation, then they come back for the second part, which is the diverting loop ileostomy creation with a J pouch creation as well. He gives that about 3 months to heal, and then after that they come in for their reversal. Laura's going to go more into depth with that, and we have a lot of fun pictures, so it'll make it a little bit easier to understand because it can be a little confusing. So Sigmoido comes to same day at 5 a.m. For his 7 a.m. case with Dr. Ramsey. He undergoes a non-complicated open J pouch, and he is transferred to the PACU. Once PACU criteria has been met, he is transferred to Monty, where he has the best nurse, Angela. All right, so he is in room 209. I am his nurse. He comes to Monty on post-op day 0. So very similarly, like we would treat all surgical patients, we have our bedside setup. That includes our continuous pulse ox, our incentive spirometer, any drain output containers that we need, we keep at the bedside. PAS stockings and pumps, so this way they don't get any blood clots. We are taking their PACU vitals, so 1 set of vitals every hour for the first 4 hours. And difference with the ERP patients is usually they're right on clears. With these patients, it's NPO with ice chips or sips of water, but sometimes they'll come out straight NPO. The reason for that is this surgery is very big, especially stage 2. That's probably the biggest procedure that they're going to have. So it's important for us to give the J pouch and the patient time to heal and make sure that everything goes according to plan, because we don't want any post-op complications to occur. A lot of times we have PCA and PCEA pumps. These patients have been chronic patients for most of their lives. So a lot of times they've had previous J pouch surgeries that just didn't take, or they are starting to deteriorate. Where they come from, a lot of times we notice we have a lot of patients out of state. So we have South Carolina, North Carolina, we recently had Alaska. So these patients are chronic. We just need to make sure pain management is our utmost priority. So Dr. Rumsey is amazing with the PCA and the PCEA pumps. It's been very effective for them because it is a big surgery. A lot of times they're on pain medications at home orally, whether it's oxycodone and Dilaudid. So we try to accommodate for that with these patients. They're also going to be on IV fluids. So usually it's between 75 to 100, depending on their hydration status. And ileostomy and colostomy care usually occur right when they get here from the PACU. Sometimes they're a little bit shaken up after the surgery, so we wait till the next day, but we try to start it as early as possible. Okay, so post-op day 1, next day. So now we're going to advance their diets as tolerated. They're not going to have any carbonated beverages. We're going to start with NPO, then move very slowly NPO with ice chips, then to clears, then to fulls, and then eventually to low residue diet. We do this because, again, it is a very big surgery. Strict intake and outputs, specifically through any drains that they have, their ostomies, to see if they have bowel function, things like that. Their pain management, again, PCE and PCA pumps. We take care of any PICC lines and ports, make sure those are nice and clean using our chlorhexidine wipes, TPN, and we encourage early ambulation. We do have our ostomy nurses on board as well, which Laura is going to talk about her side as well. And we maintain IV fluids for the entire duration of their stay. Whereas with the ERP patients, we discontinue the IV fluids as soon as they start tolerating a low fiber diet. That's me. So some care consults that we have. So we have physical therapy. We try early ambulation. We don't wait for physical therapy to come. We try to get them up and walking, or at least out of bed to the chair as soon as possible, as soon as they can tolerate. But physical therapy will be coming to see if they have any needs for outpatient. Nutrition has been amazing, so they kind of help us out throughout the way if they're going to be on full liquids for a longer period of time before we transition them to low fiber diet. Pain management with the pain pumps has been amazing with us. Very rare, but some patients do come out with wound vacs, and the wound team will be on board with us as well. The ostomy nurses and case management, we're going to give a big shout out to. They're over there. Hi, guys. So when you're dealing with patients that are in state, it's a little bit easier, but now they're reaching out to patients that are out of state. So we have them from the Carolinas, Jersey, all throughout the entire country, which is what it's going to be like. And we're, just like Megan said, we're going to start to reach out to international. So they really have been so amazing and working very diligently to make sure that any home care that we need to set up for these patients gets set up. We don't discharge them until they absolutely are 100% ready and we have everything in place. So good job, guys. Keep up the good work. We also have holistic nurses and patient family-centered care. So the reason why we have this is, again, chronic patients. So we try to make a family-centered approach for these patients to make them as comfortable as possible. A lot of these patients haven't been heard. They've been misdiagnosed. Surgeons won't touch them because it's extremely complicated. Whereas Dr. Rumsey has been really amazing, but not just the patients, but with our staff members as well. He's always coming up to us saying, do you think this patient is ready for this? How are they doing? I want your perspective on it. So we really try to involve their family in their care because a lot of these patients are also very young. They're 20 years old. I'm also just going to go back for a second. So this is Sigmoido's father, who is working on the incentive spirometer. We want that family-centered approach because this is not a 21-year-old male. This is a 60 to 7-year-old male. So we try to have everybody involved in the care. So with their discharge criteria, we want adequate pain management. So we try to get them, we give them time with the PCA or the PCEA pump, and then we transition them to oral pain medications. They have to be tolerating their diet. So they have to usually be on a low fiber diet is our goal to get them out. So this way they can eat as normally as possible. Adequate bowel function. So whether that is through the ostomy or through rectally, we just want them to be passing gas and having bowel movements. Physical therapy recommendations need to be set up. So if they're recommending home care, home PT, outpatient PT, things like that, home care must be set up by the case management team. And finally, the patient needs to be comfortable. Having an ostomy is not that easy. It's very involved and very intimate with this part of your body that you're not really so used to being intimate with. So at the end of the day, it's all about the patient's comfortability to see how they're feeling about it. So we like to give them some tender loving care, just like we do for everybody, but they have been amazing patients so far. All right, so now I'm going to pass it over to our ostomy nurse, Laura Benedetto.
Good afternoon, everyone. I want to just introduce myself. I'm Laura Benedetto-Rugen, one of the ostomy nurses, and big shout out to my colleagues, Lenny Ramirez and Marion Owens. So if anyone wants to realize this, a topic we don't talk about often is an ostomy. We don't talk about how we go to the bathroom. So now you have someone who has an ostomy who, as Angela talked about, is very uncomfortable with the situation. So again, we have to give a lot of TLC to our patients who are undergoing a fecal diversion or a urinary diversion, because it can be an emotional time. A lot of these patients, as we will talk about, are chronic. So they've had prior histories of ostomies, had reversals, and then it sets back a huge roller coaster of emotions to hear that they need a temporary ostomy again for 6 months. So just imagine, it's a hush-hush topic, but there's approximately, we don't have an exact number, but about 700,000 to 1 million people in this US alone that have an ostomy, that you have no clue. And when myself and my colleagues go into a room, that's the number one thing, especially my slogan is that you're still you, your plumbing has just been rerouted. And that's what we really feel, that even though you have an ostomy, you still can maintain normalcy. People of all ages have life-saving ostomy surgery, and they have many reasons of why they need to have surgery, but they also have to go on and they have to live. They have to be able to be mom, be dad, be a 20-year-old kid who wants to go hang out with his friends. So we try to give them that TLC, sit at the bedside, especially now with our numbers increasing with Dr. Ramsey and Dr. Erkin. We do give a lot of TLC, and as many nurses here, we all wear many hats, but a big part of it is being a psychotherapist, because a lot of it is that piece of it, is being the support for them to get through and to know that they can still live active and healthy lives. After recovery and finding the right pouching system, we want them to resume all normal acts of life and be able to work, go back to playing sports, hanging out with family and friends. So our role as the ostomy nurses, we have many roles. We're not just a changing service. So we don't walk around with bags and pouches in our hand to go around to empty and change people. So we are trying to foster a new kind of approach where if patients have been established, we don't need to necessarily see them unless there's an issue. And we are hoping that the staff will take on that responsibility and be able to change pouches and be there for the patient if they get to another unit and they, like I said, been established. So we have our inpatient services as well as outpatient. So when we do our inpatient, that means we are pre-oping the patients prior to surgery. We try to coordinate with the surgical coordinators of all the surgeons that you saw up there and try to see the patients when they're here for pre-surgical testing so that they do not have to come back for a second visit to the hospital. We start our teaching and our support then by including family members, as Angela mentioned. At that time, we do stoma site selection. So we are the ones who will take the time, have the patient sitting, standing, bending, bring their favorite pair of jeans so that we can see where the best location for their ostomy would be. We start promoting self-care, start discussing lifestyle issues, talk about the skincare, diet, and again, giving a lot of emotional support and then continuing on to let them know what their post-op course would be like after surgery, after the recovery room, and then going to 2 Monty or 9 Monty if 2 Monty is full. It doesn't stop there. While they're in-house, we see them daily, Monday through Friday, when we're here with them. And again, focusing on family patient care, we will make phone calls to the family members so that we see them and coordinate with the family to try to make that a one visit in the morning, set our time so that we could again meet the patient and family. We do this for a couple of reasons. One, number one is support for the patient, but two, we don't want to go back 3 times because now mom's here, then Aunt Millie's here, and the boyfriend is here. We want to try to coordinate the time. During our inpatient care, we'll be teaching them about their ostomy, talking about surgery, making sure that they are emptying their pouch. That's a must in order to go home. We do at least 1 to 2 changes depending on how they're doing. One being the first one, us doing and then watching, and then try to at least do 2 others if we can, while they're participating in the care and doing it on their own, especially for the patients of Dr. Remzi's and Dr. Erkin's who are out of state. Because again, our amazing case managers are trying to find home care, but sometimes there's a delay or a snag in that process, and we need to make sure that they are getting home care. So we have to now make sure that all our patients are able to hopefully at least do 1 change themselves. And our amazing support from 2 Monty staff, for the PCAs, the RNs, everybody who are there at the bedside and have also stepped up their game to making sure that the patients are continuing their education when Marion and Lenny and I are no longer at the bedside. For outpatients, again, we will guide them, counsel them. We take tons of phone calls, emails, pictures, and try to help give them support and see them as outpatients. Because again, in the community, there's not many ostomy nurses out there to help. And a lot of the times, all the surgeons are amazing, but any ostomy related question, if I could have even a penny for every time they say to call the ostomy nurses, we'd be rich and wouldn't have to work. So it's one of those things where we're very busy in-house and after. Just to kind of review the ileoanal ileal pouch, anal anastomosis, also called the J pouch. It typically occurs in 2 or 3 stages. So the patients who are here who have UC are typically the patients who are undergoing this surgery. Ulcerative colitis only affects the colon and the rectum. So when those organs are removed, the patient is disease-free, thank God. And they have this ability now to have what we call an internal pouch. It's their new rectum. So when patients are sick, they typically will have a 3-stage procedure. A lot of Dr. Remzi's patients, as he is known as the Jesus of J pouches, if you look at Facebook, jpouch.org, if you look at every site, you'll just see Dr. Remzi, Dr. Remzi, Dr. Remzi. So a lot of these patients are looking for help. Sometimes it wasn't done correctly. They're having problems. It's been 20 years since their pouch. So now they're coming back and looking for help. So they're coming to us, which now we have to learn to take care of this new patient population. So with the J pouch, what's going to happen is the first stage, I don't have a mic. Okay, so the first stage here in this picture, they're going to remove the colon, but they leave the rectal stump. They do that because it is a very long surgery, and a lot of the patients come in malnourished. They come in and they have issues with eating. They are what we call bathroom cripples, running to the bathroom 20 to 25 times a day. They walk into a store, the first thing they do is look to see where, not the exits are, where the bathrooms are. So when they go in, so for surgery, the first stage, like I said, is removal of the colon. They leave the rectal stump. And then they will create an end ileostomy. Those patients then will be teaching them, the staff will be reinforcing the teaching, they'll go home with supplies, home care, and then they'll come back hopefully within 3 to 6 months for their second stage. And like Angela said, that's the larger of the surgeries. Oh. In the second stage, what happens is that they now remove the rectal stump. They remove the rectal stump, but they leave the internal and external sphincters and the anus, obviously. They then take down the end ileostomy and they create a J pouch from the small intestine. And it's shaped as a J. They've had this over many years, and basically the idea is that they've had W's, S's, shapes, configurations, and they've figured the J is the most reliable creation. So now the J pouch is created and it's connected right to the sphincter, and now they'll go up higher and create a loop ileostomy. So with the loop ileostomy, because it's higher now up in the small intestine, because they needed to use so much to create the pouch, the patients now are at risk for dehydration, and they also might need now extra fluid and extra TPN. With that being said, they can, yeah, someone's on the, okay. If anyone's on Teams, I think your mic, if you could just turn it off. Sorry, I'm getting feedback, sorry. In regards to this, in both stages, stage 1 and stage 2, 1 being that the rectal stump is remaining, and stage 2, the J pouch is there. Patients will still have some, they'll have at times discharge from their anus. So they'll have that feeling of, ooh, I have to go to the bathroom. Sometimes there'll be mucus, sometimes it'll be a little green, like the color of the small intestine. So again, that's normal. So if they come in and say, Angela, look, I just went to the bathroom from my bottom, I thought I was only coming out from the ostomy, it's a normal occurrence. That's the second stage. In the third stage is when they come back 3 to 6 months later and they have the reversal, and then thankfully they'll be now no more stoma and having to use their J pouch as their internal reservoir, kind of like their rectum. We also go in to try to teach them about that surgery, because after once the J pouch is functioning, patients are going to expect to go to the bathroom, you know, about 6 to 10 times initially. So then you say, well, why if they were going so often before, they're still going a lot? And you're right. The difference is that these patients before surgery never had control. They were, like I said, bathroom cripples and would just run to the bathroom all the time and with frequency and urgency. So now, thankfully, with the J pouch, they'll have control and be able to have not that issue of constantly running to the bathroom. When patients have 2-stage procedures, thankfully, they're not usually sick. So what occurs is that the first stage, sometimes you'll see this for patients who've had a long history of UC, 20, 25 years, never had surgery, never really had flares. But what would happen is that in the second 2-stage patients and those UC patients, they have a high risk of developing colon cancer. So on their routine surveillances, what happens is that they come up and they'll start to see that they get dysplasia. They'll watch it, but then when it becomes high grade, that's when they'll have to come in to have surgery. So like for instance, tomorrow, Dr. Procaccino has a patient who's had UC for 30 years, and he himself, you know, has been being watched, and now unfortunately it's at that high risk, and he has to now have the J pouch creation. So he, because he wasn't sick, he was faring well, eating, drinking, doing everything he needed to do, he'll be coming in for this first stage, 2-stage procedure. So tomorrow he'll be having a total abdominal colectomy, everything removed, including the rectum, creation of a J pouch, and then a diverting loop ileostomy. 3 months, 4 months later, he'll be back to being reversed. So again, it's just another depiction for you just to see the different stages. So again, stage 1, colon's removed, rectum stays, and ileostomy. In stage 2, the rectum is removed, J pouch is created, which is made of small bowel, goes up higher to divert with a loop ileostomy, and those patients will have either a white bridge or a red rubber catheter to help support. And then Lenny, myself, and Marion will usually take those out day 2 to day 5, depending on the surgeon. And then the patient will come back 3 to 6 months later, and they will have their ileostomy closed. Just briefly to talk a little bit about a stoma assessment, it's important as nurses that your assessment of your stoma should be included in your daily routine of looking and assessing for bowels, but also looking at the color, the height. It usually could be either flush, budded, or retracted. Obviously, the surgeon's going to do his best to make a budded stoma because we all know that will make life easier for pouching. The stoma is going to be very swollen for the first 6 to 8 weeks. So over that course, it will be getting smaller. It's important to measure weekly. You want to take into consideration the size of the stoma. It could be round, it could be oval shaped. It depends on how the surgeon creates the ostomy. We also want to assess for the function of the stoma. Is there presence of flatus? So you will start to see air in the pouch. You'll also start to hear the noises in the bag. So you'll hear the noise. We get excited about that. It's party time because things are waking up. My Tumonti crew can know that and realize that. Then we start to look at the effluent and stool. So initially it's going to be more of a bilious, green, and then eventually it will start to get to be more of a liquid to toothpaste consistency. So with an ileostomy, that's the consistency that we will find. It will never be a formed stool. It'll be basically toothpaste-like, and the patient will have to empty 4 to 6 times a day. So if you're on a floor that's not 2 Monty or 9 Monty here today, and you're on another unit, 2 DSU or 6 Monty, just be aware that you would always want to make sure if your patient does have an ileostomy and he's or she too ill to get up to empty on her own, that you are emptying the pouch every, twice a shift, every 4 hours. This way you don't have an issue with leaking. The skin around the stoma should always be clear and intact. So just to talk a little bit about the different type of stomas, ileostomy versus a colostomy. Ileo, meaning from the ileum of the small intestine. The effluent is going to be liquid. Because of the enzymes in the small bowel, it's going to be more acidic. So we just want to make sure that we're always sizing correctly. Output from the stoma should be less than 1,200. However, with Dr. Remzi's patients, we are allowing patients to go home above 1,500, but for them to monitor. And we give all our patients a stoma record sheet so that they have to record their daily output. You want to make sure that we teach our patients to empty the pouch whenever it's a third to a half full. With a colostomy, depending on where it is in the bowel, will tell us what kind of consistency it will be. Obviously, the closer you get down towards the lower part of the colon, towards the left, towards the rectum, the stool will be more formed. So for our patients who have a descending or sigmoid ostomy, they're pretty much in a couple of weeks, they'll hopefully get back to their regular routine of only going once or twice a day, and they'll be a good candidate for disposable pouches. So our best practice as clinicians in acute care, it's vital to provide a comprehensive ostomy teaching and management discharge plan. So during our teaching, we always cover anatomy and function. We get them to be independent. We want them to be able to empty and change the pouch, again, with the help of our wonderful staff on 2 Monty, RNs and PCAs alike, 9 Monty. We get them to go back to being normal. We talk about diet, especially with an ileostomy, symptoms of a blockage and how to treat them, how to manage gas and odor, go over about product supply. We send all patients home with supplies to get started until home care is arranged, and we provide them a folder with all our contact information and everything we covered for their time here. Just briefly to talk a little bit about the closure. Obviously, it's based on the colorectal surgical team, but usually patients will begin having gas and flatus via the anus, whether it's a closure and they have their rectum or the J pouch 1 to 2 days post-op. Again, patients for the J pouch could experience initially 12 to 15 bowel movements a day, but again, within a year, thankfully, they'll average about 4 to 6 pasty formed BMs, but with control, thankfully. We do want to start skincare early. Perianal skincare is started early because we want to prevent any kind of perianal irritation, because it can become very severe, like a very bad diaper rash. So obviously, their risk of developing irritation is related to an increase in bowel action, so that their transit time is decreased since they've already had, their resection of their intestines. We try to have them avoid certain foods like caffeine and onions and spicy foods. They can increase irritation. In regards to the skincare, we'll just have everybody, put on Baza from the beginning and just teach them how to apply. And lastly, we were able to, in the summer, officially have a ribbon cutting ceremony for our outpatient clinic. So we are in the process of seeing patients on Thursdays. on the 1st, 3rd, and 5th between 8 and 12 with the help of our wonderful MPs, Liz and Dottie, and then Fridays on 1 to 3. So we try to coordinate and try to see patients with issues. Thank you, everybody.
Just quickly to wrap it up with some of the involvement that we have within the community, especially we were lucky enough to have our team join us from 2 Monty here. This is County Executive Bruce Blakeman, who awarded us a proclamation for Colorectal Cancer Awareness Month this March. We've done it 3 years, and he liked the dome blue on Franklin Avenue, which is the Franklin D. Roosevelt building, which is pretty exciting. And of course, it's extremely important because March is Colorectal Cancer Awareness Month. And with that said, I'm going to turn it over to Barbara, and she is going to go over this beautiful poster and of course focus on what is important with colorectal cancer awareness.
Yeah, this will be quick because you can see, you know, why it's important to get screened. So March, like Megan said, is Colorectal Cancer Awareness Month. And I just want to share a very personal story with you, a couple of minutes. My cousin Bill, on December 30th, passed away from colon cancer with a 6-year battle. He was, we were at a barbecue 6 years ago, and he asked me if it was a bad thing to have bleeding from the rectum. So he had it for about 6 months, and I told him it could be, but it may not be. But here's the card of a very wonderful colorectal surgeon that we have here at North Shore, who took him in very quickly, and he was diagnosed with colon cancer. So he endured 6 years of chemo, radiation, multiple surgeries. One was a 12-hour surgery in ICU, multiple interventional radiology procedures, chemo, oral radiation, oral chemotherapy, radiation. It just went on and on and on. And he fought the fight, but it was because he had not gotten his colonoscopy. So this poster, some of you may remember it from my old collaborative care days, but I dusted it off, took it out of the computer attic and put in some relevant information, all gotten from the American Cancer Society. And I would suggest that people go on and look, because it would be a big encouragement to you to get a colonoscopy, to encourage your family and support them to do it. So it is the second leading cause of cancer deaths in the U.S., and it is more common in men than women. And according to the American Cancer Society for 2024, the U.S. estimates are new cases will be 152,810. That's a heck of a lot. Deaths will be 53,010. However, the rates in younger patients, younger than 50, have increased by 2% per year. Correct me if I'm
Yes.
okay.
Correct.
So that's frightening to me. Overall rates for colon cancer have decreased over the past 10 years, including those 65 and older. But those 55 and younger, it's increased. So it's important that they get screened. And I believe it is at 45 now, correct? Would be normal screening for those who are 45. However, I believe that it is, if you were diagnosed, say at 45, your first degree relative, mother, father, sister, brother, has been diagnosed, you decrease it by 10. So if they were diagnosed at 45 years old, you would need to get screened at 35. So what is colorectal cancer? I know most of we will know what it is. It could be a cancer in the colon or rectum with abnormal growths called polyps. Over time, some polyps may become cancerous. That's why getting screened is important. So what are the risk factors? It's very preventable. Family history, which is not. Poor diet, red, grilled, processed meats, heavy alcohol use, not getting enough physical exercise, type 2 diabetes. The signs and symptoms could be change in bowel habits. Maybe you're not having bowel movements, or you're having rectal bleeding, dark or bloody stools, and unintended weight loss. So the 6 ways to protect your colon health would be to get screened starting at age 45. Eat fruits, vegetables, whole grains, minimal red, grilled, and processed meats. Get regular exercise, watch your weight, stop smoking, and limit your alcohol use. And really talk with your doctor for screening. People ask me, what about the Cologuard? And I say, talk to the doctor. Talk to your doctor. It may be appropriate for some people, but, most people, like you said, the gold standard is colonoscopy, and it's not terrible. I've had a couple of them. It's not terrible. And it's the best sleep you're ever going to get, really, for 20 minutes. And again, please go on the American Cancer Society website because it's so important, and please encourage your family and your friends because you really could be saving a life. Thank you. Thank you.
It's a very important message, Barbara. Thank you for sharing. Also, just to give a little perspective, it's now the second leading cancer cause of death, and it was the third. So that is pretty important to say with that. And also, screening was 50, as Barbara had said, and it's now 45 because of the uptake in the younger population. So there is a reason for concern, and that's why we also passionately advocate for that. And it's great to have colleagues as well who are passionate about that. So I know we have 5 minutes left, but this is a 1-minute video. So let's see if the volume will play. If not, we will take some questions. Let's see the volume. Let's see. Hold on.
Can be a very stressful situation. And that's compassion and innovation is a unique combination. My name is John Procaccino. I'm the chief of the Division of Colon and Rectal Surgery here at North Shore University Hospital, which is part of Northwell Health. We practice state-of-the-art colorectal surgery, and that can include innovative, minimally invasive techniques such as laparoscopic and robotic surgery.
I'm Dr. Mark Greenwald. I'm the Chief of Colorectal Clinical Services here and the Program Director for the Rectal Cancer Multi-Disciplinary team. We have 8 colon and rectal surgeons and a terrific multidisciplinary team. We have our own floor, our own ORs. We meet regularly to discuss patient care and management. Our team includes the nurses, physical therapists, dietitians, anesthesiologists. All of us get together on a regular basis to make sure that we provide the best care for our patients with colorectal problems.
Our focus here is to take a multidisciplinary approach to each patient's problem, make sure that we individualize the care for that person.
For the patient that has colon surgery at North Shore Hospital, we are able to free them more quickly, get them out of bed more quickly, and return to their regular daily functions more quickly. That's what enhanced recovery does.
One of the interesting aspects of colon and rectal surgery is that you can deal with very minor rectal problems that can be very vexing for patients and runs the full spectrum up to some very complex issues such as inflammatory bowel disease, that would be ulcerative colitis, Crohn's disease, diverticulitis, which is another inflammatory condition, and importantly, colorectal cancer, which is obviously a very, very significant issue. One of the things we're most proud of here at North Shore is that we rank amongst 90th percentile in most likely to recommend, which gives credence to the fact that patients have a very positive experience here at our institution.
And it is an absolute pleasure to work in a place where everyone is centered on making sure that patients get the best possible care.